Okay, a 76-year-old woman comes to the office for evaluation of leukopenia. The patient came to United States to visit her son a month ago and was seen at an urgent care clinic 2 weeks ago for acute sinusitis, where she was found to have leukopenia. She was prescribed an oral antibiotic and repeat blood test was advised. The patient has 2 episodes of skin infection over the past 3 months. Okay. She also has had pain and swelling in the joints of her hands, knee, and for the past several years. The patient does not use tobacco, alcohol, illicit drugs. Temperature is 37, blood pressure 130/80, and pulse is 74. Physical examination shows normal heart, lung sounds, moderate splenomegaly, generalized lymphadenopathy, no sinus tenderness, and well-healing lower extremity ulceration. The small joints of the hands are swollen and deformed. These are the laboratory findings. And additional evaluation of this patient is more likely to reveal which of the following. Anti-citrullinated peptide antibodies decrease vitamin B12 levels, hypocellular bone marrow or Philadelphia chromosome. This serum monoclonal proteins as well. So she, 76-year-old woman, evaluation for leukopenia. Okay, she's in States. Oral antibiotic was given. 2 episodes of skin infection last 3 months. No pain. No, there is a pain, swelling of the joints and hands and knees. No drugs. This is fine. This splenomegaly is there, lymphadenopathy. No, this, and well healing lower extremity ulceration is also there. The small joints of hands are also swollen and deformed. So anyone have any idea that what it is? Anyone? Because for me, it's the features, some of the features, this small joints and swell and deformed, and the age also, there is pain also. Her ESR is also raised. So there is, anything is going inside her body, leukocytes. Anyone? Okay, I also have no idea, but it seems like she might, because the hands, knee, small joints, and for chronic age, it can be a rheumatoid also. English. Yes. Okay, now because it's okay, it's anti-serotype antibodies. Okay, we will read it. Okay, they are saying that it's a Felty syndrome. The clinical features of Felty syndrome is rheumatoid arthritis, where severe erosive joint disease and deformity is seen, rheumatoid nodules is seen, vasculitis, mononeuritis, multiplex necrotizing skin lesions, neutropenia, okay, and splenomegaly. Okay, fine. And the Felty syndrome, we will see rheumatoid arthritis, neutropenia, and splenomegaly. Yes, there was splenomegaly as well. Neutropenia was there. Diagnosis, anti-CCP and RF factors are positive in 90% of the patients. ESR is raised. Yes, in her case also was raised. Peripheral smear and bone marrow biopsy to rule out other cases of neutropenia. This patient with swollen deformed hand joints and an elevated erythrocyte, the ESR rate, likely has untreated inflammatory polyarthritis. The presence of concurrent neutropenia and splenomegaly was raising the suspicion for Felty syndrome. Okay, if we can remember this triad, rheumatoid arthritis means arthritis, neutropenia and splenomegaly. If these three are present with elevated ESR and anti-CCP antibodies and this RF factor, then it's most likely Felty syndrome. Okay, but serious complications of long-standing erosive rheumatoid arthritis. Welty syndrome is marked by the formation of autoantibodies antibodies against neutrophil components and granulocyte colonies stimulating factor leading to neutropenia, less than 2,000 mm cube, and how much was 1,800. Okay, an increased risk of recurrent bacterial infection. Yes, the patient was treated for 3 times. Here she was treated 3 times for this, 2 times in the last 3 months for the skin infection. Okay, repeated bacterial infections. Okay, skin neutrophils coated antibodies. Okay, which leads to splenomegaly. Also, the diagnosis based on the clinical features, but is supported by the presence of high titer rheumatoid factor and anti CCP and okay, bone marrow biopsy. Okay, symptoms generally improve the treatment with underlying. Okay, fine. Patient education. Where it is. Felty syndrome is a complication of seropositive rheumatoid arthritis characterized by neutropenia and splenomegaly. It's a complication of rheumatoid arthritis. Most patients have high titer of rheumatoid factor and anti-CCP. Okay, both of which are also elevated in rheumatoid arthritis. Risk of recurrent bacterial infection is significantly increased due to neutropenia. Okay, so another question is a 51-year-old 51-year-old woman comes to the office due to 2 months pain and numbness of her right index and middle finger. Her fingers turn white when subjected to cold, and they hurt until she thoroughly warms them. Okay, her fingers turn white when it's under cold, and until she warms them thoroughly, it doesn't improve. The patient has no problems with her left fingers or toes. Medical history is significant for chronic cough, lower back pain, acid reflux disease. She has a 28-pack-year smoking history. On examination, there are 2 small ulcers on the tip of her right index finger. Which of the following is best? Next step in the management of this patient. Antinuclear antibodies. Okay, how we will manage it? Anteriogram, losartan therapy, thyroid function studies, transthoracic echo. Anyone?
Yeah, arteriogram.
What is getting in your mind? Because for me, this her fingers are numb. I think so. 2 days back, also we discussed this thing that the fingers get cold, the extremities get cold, and that was, I think so, Raynaud phenomena. Although I don't
Right.
remember, but this I remember that while we were just discussing that the fingers get cold and bluish.
Yeah, that happens in Reynolds. Yeah. So one of
So what's in if it is the Renault and she's okay, fine. She's having and it was common in smokers also. She's having a history of smoking also. And see, it is only the fingers, right index, and there are ulcers also over there.
not in the left ones, right? Yeah.
So I don't know much about that, but I just remember this that it turns white and it's that, and it's only in her one hand with left fingers only in the right hand, and the left fingers have no issues. She's having a history also this. I have no idea. Okay, this is anti-nuclear antibodies, that is ANA. Okay, yes, it was Raynaud phenomena. Primary Raynaud and secondary Raynaud. No underlying cause of primary, usually in women age less than 30. No tissue injury, negative ANA and ESR. Management is avoid triggering aggravating factors and CCB for calcium channel blockers for persistent symptoms. Okay, primary is there is no underlying cause. In women less than 30, she was 51. No tissue injuries there, negative ANA and ESR. Avoid aggravating factor and CCP for present. Secondary is connective tissue disease, occlusive vascular condition, symptomatic sympathomimetic drugs, vibrating tools, hyperviscosity syndromes, nicotine. Nicotine is seen in cigarettes. Okay. In men greater than 40, symptoms of underlying disease will be there. Tissue injury or digital ulcers. Digital ulcers, yes, there she
Yeah.
was having the ulcers. Okay. Tissue injury will be seen and the digital ulcer, abnormal nail fold capillary examination. Abnormal nail fold capillary infection. Okay. Evaluate and treat underlying disorders, CCB for persistent symptoms, aspirin for patients at risk for digital ulceration. Calcium channel blocker for persistent symptoms. Aspirin for patients with at risk of digital ulceration. So in this scenario, we will not give aspirin, right? Because she's already having the ulcer. We will just give her a CCB, right?
Mhm.
Okay, this patient features suggests a renal phenomena which is caused by abnormal vasoconstriction of digital arteries in response to cold or emotional distress. It's not associated with any systemic disorder, but secondary. Okay, patients typically present with sudden onset of cold at extremities and sharply demarcated color changes. Okay, yes, white and blue. I read blue. Okay, primary typically affects young patients, where who have symmetric episodic attacks without tissue injury. Secondary, older and asymmetric. Like she was having attacks only on the right fingers and her left fingers were spared. Okay, with clinical features of tissue ischemia, that is numbness and ulcer. Okay, and systemic disease, which is autoimmune vascular. She was not having anything. Okay, this patient features okay, no history and physical examination. Okay, A and rheumatoid factor will be done. Okay, the patient education is Raynaud phenomena is abnormal vasoconstriction of digital arteries in response to cold or emotional stress. It may be primary or may occur in association with any systemic disease, especially autoimmune disorders. Patient with suspected this should be tested for auto antibodies and inflammatory markers. These are the autoantibodies, that is ANA, rheumatoid factor, inflammatory markers, ESR, and complement levels, C3, CO, urine analysis, complete blood count, and metabolic panel. Okay. And you were saying this arteriogram, it's for Burger disease, small and
Yeah.
medium-sized
White
arteries. Okay,
vasculitis, yeah.
here it is the smoke. Okay, and Raynaud family, yeah, Raynaud is also associated with smoke, nicotine. But okay, Birch is also associated with smoke. And distal ischemia is also there, ulcer is also there, gangrene is there. More common in men, 4 to
Mhm.
45. Diabetes, autoimmune, hypo, therefore ANA and other blood tests should be obtained prior to a. Okay, fine.
Because it's an
But
invasive, so
yes,
that,
if it
yeah,
is
yeah.
this disease as well, also, then also we will do ANA. Initially, we will
And
do
if,
ANA and then arteriogram will do it.
mm,
So this, this Burger disease and Raynaud is quite similar because distal extremity is involved, but this leads to gangrene It's 40 to 45, and patients who smoke, it's common in men, and here they have the written info. So how to differentiate this? If this is the scenario, so how will we differentiate these two? Purge disease versus this and Raynaud phenomena.
So they're saying that it's diagnosis of
Because see,
exclusion,
this is
right?
also 40 to 45, same
Yeah.
age. Smoke, that is also smoking. Extremities are involved, which is leading to just gangrene is something new. Otherwise, there is, ischemia is also happening over here, which leads to numbness and this ischemia, tissue ischemia is there.
So that's why we need to do the other test before, because it's the diagnosis of exclusion. After we have excluded those, then we'll go to Berger disease. Yeah.
Okay. So we have to
Yeah.
do arteriogram or anything, ANA, rheumatoid factor, ESR, and complement levels. We do it first. Okay. A 55-year-old woman come to the office with the right pain in the right shoulder for past 2 months. The patient is unable to raise her arm or to reach her objects. Her right hand is dominant, but she has recently been using her left more due to the problem on the right. The patient lives with her disabled spouse who has a stroke 8 months ago. Before the pain, she had taken care of his daily activities and helped transfer him from his bed to wheelchair, but it is now unable to do so. The patient's other medical conditions include type 2 diabetes, Graves' disease, hypertension, and hypercholesterolemia. An examination says markedly decreased passive and active abduction. Passive and active abduction, flexion and rotation of the right shoulder, palpation of the shoulder, acromial, acrom,
Acromioclavicular.
acromioclavicular femur-clavicular joint do not reproduce the pain. Palpation of the shoulder and acromioclavicular joint do not produce pain. The remainder of the physical examination and markable X-ray the show is.
What is the most likely cause?
Okay, adhesive capsulitis, calcific tendinopathy, osteoarthritis, rotator cuff tear, rotator cuff tendonitis.
What was the age of the patient? Was age mentioned?
55. Now I think it's related to rotator cuff.
Yeah, because it's more because of the mechanical injury, right? She
Yes,
was taken.
either it is tear or tendonitis. But more, I think so. It might be a tear because she was transferring his husband from the bed to the
Yeah,
wheelchair. लेकिन रोटेटर कफ क्या वो उठा के गोद में ऐसे करके?
most
Okay.
probably.
No, it is
No, it's
capsulitis. Okay, what is that? The common cause of shoulder pain is rotator cuff. था ना rotator cuff, तो वही करते हैं. Adhesive capsulitis, okay, frozen shoulder, yes. Decreased
older.
passive and active range of motion, stiffness and pain. Was she having any stiffness?
Yeah, stiffness, decreased movement. There was decreased movement, right?
But what about stiffness? No, there was no stiffness. No. Okay, so adhesive capsulitis is frozen shoulder, passive and this range of motion and stiffness and pain is there. And adhesive capsulitis is characterized by pain and loss of distendability of glenohumeral joint capsule due to chronic inflammation, fibrosis, and contracture. It is often seen in patients with diabetes, thyroid disorder, chronic immobility, rotator cuff tendinopathy, and fracture of the proximal humerus. Examination shows decreased active and passive range of motion in multiple planes. X-ray findings are normal. Okay. The most common causes of shoulder pain is rotator cuff impingement, in which there is pain with abduction and externalization, subacromial tenderness, and normal range of motion. We'll be having a normal range of motion, but positive impingement test of his Mears and Hopkins and rotator cuff tear, which we were thinking that it's similar to rotator cuff tendinopathy, weakness with abduction and external rotation, weakness with abduction and external rotation. And here she was having, decreased passive and active abduction, rotation, and flexion. Flexion was also there. Okay, and normal range of and the age is greater than 40, weakness with abduction and external rotation. Adhesive capsulitis, that is frozen shoulder, which is the answer. Decreased passive and active range of motion. Stiffness with or without pain. Decreased passive and active range of motion. Stiffness with or without pain. Biceps tendinopathy or rupture, anterior shoulder pain, pain with lifting, carrying, or overhead reaching, weakness. Uh, Glenohumeral osteoarthritis, uncommon and usually caused by trauma, gradual onset of anterior or deep shoulder pain, decreased active and passive abduction and extension. Okay, this patient has chronic shoulder pain with decreased passive and active range of motion, with, with decreased passive and active range of motion consistent with adhesive capsulitis, sometimes termed as frozen. Adhesive capsulitis is characterized by loss of normal distentability. Okay, distentability will be lost. Okay, of the glenohumeral joint capsule due to chronic inflammation, fibrosis, and contracture. It is common in middle-aged and an older individual, and the risk is increased in patients with diabetes mellitus, thyroid disease, and chronic immobility. It is common in patients with a beta cuff tendinopathy or fracture of the proximal humerus. Patient with adhesive capsulitis typically report gradual onset of stiffness, that limits the ability to flex, abduct, or rotate the humerus. The diagnosis is confirmed by demonstrating a reduction in both passive and active range of movement in multiple things. X-ray finding, as in these patients, are usually normal, and imaging is primarily to rule out other causes of pain. So we were all thinking about rotator cuff. So calcific tendinopathy, osteoarthritis. Okay, this one. Rotator cuff tear often follow an injury. Okay. Okay. Like fall on or outstretched hand. Okay, that is why it was not rotator cuff tear or what was the tear or infection. And typically causes weakness with active shoulder abduction and rotation. Rotator cuff tendinitis is an overuse syndrome. Okay, that is why it was not rotator cuff tear, because it starts here. It happens after when you have a trauma or injury, like you fall on your outstretched hand, and rotator cuff tendinitis is known as overuse syndrome, characterized by painful abduction and external rotation. That is heavy lifting above the shoulder. Okay, we are overusing this, our overuse of the muscles lifting above the shoulder. Then it occurs tendinitis. Patients with these disorder may resist manipulation of the arm because of pain, but passive uh, range of motion is normal. Adhesive capsulitis is characteristic of pain and loss of distendability. Okay, distendability is lost. Okay, and this due to chronic inflammation, fibrosis, and contraction. It is often seen in patients with diabetes, thyroid, chronic immobility, and rotator cuff tendinopathy, and fracture of the proximal humerus. Examination shows decreased active and passive range of motion in multiple planes. X-ray findings are usually for normal, whereas in rotator cuff, it is outstretched, and rotator tendinitis, it is overused, like is using the heavy lifting above the shoulder causes this, and the patient with these disorder may resist manipulation. They resist manipulation of the arm cause of pain, but passive range of motion is normal.